one more comment. Sorry, I want to come back to something that we all know, but this is this notion, and this is Alexandra's comment from yesterday.
Hi, everyone.
Take the example.
Hi, everyone. This is Shabir Musa here. It's great to have you all on board. Let's just see who's joining us.
Palliation is a little bit more obviously.
Yep, I think people are joining us slowly.
Unavoidable because we all die, and we know that
we'll just give them a few minutes before we start.
Well, we are going to need.
Sorry, let me just get rid of something disturbing us. Great. I think we've got 14, 15. It's growing slowly. Sorry, apologies for the late start. All right, well, welcome everyone. My name is Shabir Musa. I'm a family physician in Johannesburg, Shewelo Community Practice, and we are running the AfroPHC continuing professional development series on Thursdays. We're really pleased today to have Dr. Bharatram Nirvana, who's a fellow in the Division of Rheumatology at Chris Sanibara Hospital, as well as in the University of Witwatersrand. And she's going to share with us approach to the management of rheumatological conditions in primary health care. Dr. Bharatram, really appreciate you coming on board and doing this for us. It is the last of the CPD for this year. So afterwards, we'll wish you all a very good holiday and festive season until January. So with that, over to you, Dr. Bharatram. I'll let you continue.
Sure, thanks. Just let me know if there's any sound difficulty. So today
I think it's quite fine. And just to ask people, please use the Q&A during the meeting, and then we could deal with that.
Sure. All right, good. So today I shall be presenting on the management of common rheumatological conditions in the primary healthcare setting. So particularly a focus on what can be done on the primary healthcare setting to try and diagnose these patients quicker and refer them quicker, as well as what management can actually be done in primary healthcare. So when it comes to rheumatological conditions, sorry, I'm just trying to move my slides. So when it comes to rheumatological conditions, we have two broad categories. We have the arthritis, or patients who predominantly present with arthritis as their main complaint. Then we have our connective tissue disease, which tends to be a little bit more multisystemic in manifestation. So the first part of my talk, I'm going to talk about arthritis and the important points to know about that and how we manage common arthritis in the primary healthcare setting. And the second part of my talk, I shall be discussing the basics of connective tissue disease. So arthritis essentially refers to joint pain and swelling. Patients often complain of joint pain. I think about up to 30% of patients with musculoskeletal complaints in the primary healthcare setting come in reporting pain and swelling of their joints. It's very important to differentiate on your first encounter with a patient. Is it just pain, or is there associated swelling? And the reason is because that bodes to different diagnoses. When first assessing a patient, what important factors we need to know on history is, number one, is the number of joints involved. So is the disease or is the pain isolated to just one specific joint, or monoarthritis? Are there 2 to 4 joints involved, an oligoarthritis, or are there more than 4 joints involved, so polyarthritis? The onset of the pain is important, as it also would point to certain disease processes. So patients presenting with acutely swollen joints, you always need to worry about the concern of infection, so septic arthritis, or more commonly gout. Patients who have insidious onset of disease processes, we worry more about rheumatoid arthritis. Additive disease, often in gonococcal infections. Migratory, are we familiar with acute rheumatic fever? And intermittent presentation of joint pain and swelling is quite a typical history you have in a patient who suffers from gout. The other important point to illustrate on history is this pain inflammatory in nature, or is it non-inflammatory or degenerative? So inflammatory pain is essentially pain that tends to get worse with rest. So patients wake up after a night of sleeping with very severe pain. The pain tends to improve as they move throughout the day, and often this pain is associated with early morning stiffness. This is important because it points to often an autoimmune or inflammatory process within the joint, as opposed to your non-inflammatory pain, which points to a degenerative process within the joint. Non-inflammatory pain is pain that tends to get worse towards the end of the day. So patients wake up fine, they're able to mobilize, but as they go about their activity during the day, they notice the degree of pain worsens. And often that pain is then relieved by rest. And this points towards a more non-inflammatory or degenerative process, which we commonly see as osteoarthritis. Other patterns of disease presentation would be, is it symmetrical joint involvement or asymmetrical? Is it predominantly central joints, so your axial skeleton, or is it more peripheral joints? Is there upper versus a lower limb predominance, or is there predominantly large or small joints involved? So when you first encounter a patient, I think these are very important to try and hone in on what the diagnosis could be in that individual. Associated features which are important as well, as we mentioned, are early morning stiffness. Often note, early morning stiffness more than 30 minutes tends to be significant, or is what we consider significant, and is often again associated with inflammatory pain. This is be it in the hands, in rheumatoid arthritis, or in your spondyloarthropathies or your ankylosing spondylitis. Patients may have this stiffness in their back. Extra-articular features are also important to inquire about. So patients may have had visits to the ophthalmologist because of red, painful eyes, as in scleritis or episcleritis with rheumatoid arthritis. They may also report the development of nodules. They could also have respiratory complaints, progressive shortness of breath, or any other cardiac or GIT complaints. Particularly in your inflammatory arthritis, so rheumatoid arthritis, they may be associated with constitutional symptoms, and that's important to elicit on history. Particularly in your elderly patients, they can have quite significant loss of weight. It's important to know what medication the patient's been on, particularly chronic corticosteroid use, and what provides them relief. A family history is important because certain autoimmune conditions have a predilection to certain families, such as some genetic predispositions, and any other associated systematic features. When you're examining the patient, so you do a focused joint examination, the approach to a joint examination that we do in all our patients is that of the GAL system. So firstly, looking at the gait of the patient, looking at their arms, their legs, and then their spine. With each set of joints, you're going to look at the joint for any areas of swelling, inflammation, redness of the joint, any skin changes, any associated nodules. You're going to feel for warmth and tenderness or synovial swelling or bogginess, and you're going to move the joint. Patients who have acutely swollen, inflamed joints often have reduction in their mobility. Active movement, so where the patient moves it themselves, would be reduced. And if there's disease at the level of the bone or erosions, you may find that you've got reduction with active and passive movement. If the disease is outside of the joint, so particularly in the shoulder where you have rotator cuff injuries or rotator cuff involvement, you'll find that the patient actively has decreased range of motion, but when you passively move it, you're able to overcome this. So that's also an important differentiator when you're seeing a patient, particularly who's complaining of shoulder pain, to try and elucidate what is the actual pathology. When you're examining joints as well, you're going to look for typical deformities of conditions. So we'll go through a few of those just now, and you're going to look for any extra-articular features. So patients may present with a monoarthritis. The important differentials in this are four that are important to know is that septic arthritis. So septic arthritis is considered a medical emergency. This is a patient who you identify in the primary healthcare setting who needs to be referred for tertiary care as soon as possible. They will have a unilateral, monoarthritis, typically a red, hot, swollen joint with quite marked reduction in both active and passive movement. And if you do insert a needle inside, you may see pus on aspiration. These patients often need urgent orthopedic intervention and drainage. The other common cause for a monoarthritis is that of a crystal arthropathy, of which we commonly see gout. And I will go into a little bit more detail with gout just now. And the other two differentials not to forget is that of trauma or hemarthrosis. Hemarthrosis, often in your younger male patients who present with these spontaneous swellings of the joint, you need to also consider the back of your mind diagnosis of hemophilia. And if you do aspirate a joint and you see frank blood coming out, that patient again needs to be referred for investigation. Always bear in mind that there can be members of an acute monoarthritis, particularly when the swelling extends beyond the joint capsule, and that could be in the form of a cellulitis, a bursitis, or tendinitis. So when you see a patient with a swollen joint, a swollen knee, a swollen is the most common, actually, that probably the easiest to aspirate or attempt aspiration of an ankle or elbow, but we wouldn't recommend it unless you've had experience. But a knee, if you've had experience before, can be aspirated in the primary healthcare setting. You would send off your fluid for MCNS and culture. You would also look for crystals and for cell count. If when you aspirate, as we said, there's blood or pus, that patient needs immediate referral to a tertiary center. As part of your investigations, you will also do an X-ray and certain laboratory investigations to try and tailor your diagnosis. So moving on to gout. So gout is one of the most common inflammatory arthritis that we see in the primary healthcare setting. And patients often present with these acute attacks where they have a swollen first MTP. It may be associated with an alcohol binge, there may be associated family history, but it's important to be able to recognize and also be confident in the treatment of gout. So gout, as we said, is an inflammatory arthritis. It's due to an excess circulating uric acid. The uric acid level may either be elevated because of an under-excretion at the level of the kidney or due to an overproduction in uric acid. So the risk factors that we have for gout are dietary factors. So patients who have very high purine intake, so either from red meat, organ meat, sardines, shellfish. Those are generally your highest intake of purines, and those get broken down into uric acid. Other risk factors to consider are patients who have high intake of fructose-containing drinks, as well as certain medications, as we know, TB treatment, as well as hydrochlorothiazide. So identifying risk factors are important, and the typical history that the patient will present with is that of swelling of their first MTP, intermittent attacks. So between the attacks, they're actually quite well. They may or may not have a family history. It often occurs in the context of a patient with metabolic syndrome, and important to identify the risk factors. When you examine the patient, they often have a red hot swollen joint, and swelling tends to extend beyond the joint capsule, so it may even look like a cellulitis. And occasionally you can get presentation of more than one joint, so oligoarthritis. And when the disease progresses, you get polyarticular gout, and you may or may not have tophi visible on the skin. As we said, when we diagnose gout, we do an aspiration of the joint, and you see these negatively birefringent needle-shaped crystals. So gout has 4 stages, and it's important to understand this because this determines how we target therapy. So you have a period of asymptomatic hyperuricemia. These patients just have circulating high uric acid levels and may or may not present with acute flares of gout. When the uric acid precipitates within the joint as monosodium urate crystals is when you develop an acute flare. In between the acute flares and your uric acid level settles, patients actually are quite well and asymptomatic. As these flares continue, they then develop to chronic gout or chronic tophaceous gout, so we may develop tophi on the peripheries. However, they may also develop advanced gout complications, so tophi within the kidney, so nephrolithiasis and urate nephropathy. And the disease progresses as we have this a rise in the level of uric acid and progressive uncontrolled hyperuricemia. So how do we manage patients with gout? So when a patient comes into you with an acute flare, we would firstly try and manage that flare. So the options we have are paracetamol, colchicine, non-steroidals, and lastly corticosteroids. The first line that we recommend would be a simple paracetamol with colchicine. Colchicine has an anti-inflammatory effect, and we can give it at a dose of 0.5 milligrams BD. In the context of renal dysfunction or particularly elderly patients, you may choose a daily dose. With that, if there's no contraindication to non-steroidals, you can use non-steroidals, particularly naproxen, to help to alleviate the acute flare. Patients in which there's a contraindication to colchicine or non-steroidals, in most cases that's in the setting of renal dysfunction, you have the option of using corticosteroids. If it's one joint, you can inject into the joint, or you could consider a short course of oral corticosteroids, usually 30 milligrams, which is weaned between 7 to 10 days. So that settles the acute flare. However, that does not, for the long term, lower the uric acid levels. So how do we treat gout, chronic gout, and who do we treat? So patients who come in with 1 or 2 episodes of gout years apart don't actually require long-term therapy. And because these patients are often through lifestyle or risk factor modification, we can actually prevent future attacks. The patients that we actually initiate uroid lowering therapy on are patients who have more than 2 attacks of gout per year. If they have chronic tophaceous gout, the presence of gout on their hands, their feet, their elbows, extremities, you look on the ears, the back of the head. If they have tophi, that's an indication for uroid lowering therapy. Patients who have erosive changes on X-ray, any patients with renal involvement, as well as patients with a uric acid level of more than 0.54. These are the patients that we're going to start our uroid lowering therapy on. So in the primary healthcare setting, we have access to allopurinol. And how do we start treatment? So over the years, the treatment or the management of gout has changed. Initially, patients would just be put on this blanket dose of 300 milligrams, and that was probably the end of their management. Now, what we found is that to actually start a patient on a lower dose of allopurinol, there has been slight decrease in their risk of flare, and you slowly up titrate the dose of allopurinol, and we are treating to a target. So that's a big change that's come about in the management of gout, is that we actually treat to a target serum uric acid level. So essentially, if you're in a primary healthcare setting and you see a patient with gout, provided there are no contraindications, you start your patient on allopurinol at 100 milligrams a day. You would ideally want to review the patient in a month to make sure that there's no side effects of the medication. If not, you would see them after 2 or 3 months. And you would ask them ideally to do a uric acid level before they come to see you. If the uric acid level is more than 0.36 or more than 0.3 in the presence of tophi, you would then go up with the dose of allopurinol. And you can go up in small increments of about 50 milligrams. And eventually you can go up to quite high doses. We're looking at the maximum dose of 900 milligrams. But typically once you reach your 500 milligrams, your patient is generally controlled. With that though, when you initiate a patient on allopurinol, because of mobilization of the crystals, there is a risk that they can flare. So a lot of patients will tell you they are averse to taking allopurinol because it worsens their disease. So what the American College of Rheumatology has recommended is that together with instituting allopurinol for a patient, you start them concomitantly on prophylaxis. So the prophylaxis is given for a period of 3 to 6 months as an overlap with allopurinol to try and decrease these risks of gouty flares. The agents that can be used are colchicine, so 0.5 milligrams BD or 0.5 milligrams daily if a patient is elderly with renal dysfunction. You can consider non-steroidals, however, bear in mind there are quite a few contraindications to use of non-steroidals. Or if no other medication can be used for prophylaxis and the patient is at high risk of flare, you can give them a low dose of prednisone, 5 milligrams, to overlap with the initiation of allopurinol for at least 3 to 6 months. And this is how we would manage these patients. Together with that, importantly, as we mentioned, is modification of risk factors, so stopping alcohol, decreasing foods which have a high purine content, high purine and fructose content, as well as together with weight loss. Switching out whatever medication that put them at risk as possible, so removing hydrochlorothiazide, as well as if they're on an ACE inhibitor, we prefer to use losartan because it has uricosuric effects, so that patient may actually require albuterol if they're also uncontrolled hypertension. So this essentially can be done in a primary healthcare setting. So at which point do we then need to refer a patient with gout? And the patients with gout that need to be referred to specifically a rheumatology clinic are those who have refractory disease. So despite increments in allopurinol aiming to a target, they're still not achieving adequate control. Those patients can be referred up for further evaluation. And importantly to look, is there any other pathology that may be contributing to the high uric acid? And in that looking for malignancy, or also patients with complicated disease. So patients who have very extensive tophaceous disease, there's risk of tendon rupture. Often those patients need to be evaluated in a tertiary center and sometimes even by the hands unit or orthopedic surgeons to see if removal of tophi would actually improve function. So gout management is something that we really need to be comfortable with because it often affects our population who are working, who are breadwinners, and early institution of therapy can actually prevent the development of tophi and reduce the morbidity and that these individuals experience. The other thing to remember, gout has actually been labeled as a curable disease. And the reason is because as you mobilize these monosodium urate crystals, you can actually get resolution of tophi. And this also improves patient functionality. So next I'm going to move on to polyarthritis. So polyarthritis is a patient who presents to you in a primary healthcare setting with complaints on multiple joints. They have more than 4 joints that are not only painful, but visibly swollen, or the synovitis of the joints. And there's a number of conditions that lead to polyarthritis. Most commonly, we see rheumatoid arthritis, crystal arthropathy, so gout, which is more polyarticular in the later phases of the disease, connective tissue disease associated to systemic lupus, and the less common entities to consider are seronegative spondyloarthropathies, so psoriatic arthritis, reactive arthritis, arthritis in association with endocrinopathies, infections, malignancy, sarcoid, and erosive forms of osteoarthritis. So how do we broadly investigate patients with polyarthritis? So as we said, important to recognize the pattern of joint involvement, any associated features, early morning stiffness. Look at your patient profile. In terms of laboratory investigations, you want to do your basic full blood count together with a differential count, your acute phase reactants, so inflammatory arthritis often have an elevation in your CRP-ESR. In terms of antibody testing, at the onset, you would just do a rheumatoid factor and or ANA, if you're concerned that there could be an inflammatory arthritis, and you would consider x-rays of your hands and your feet. For patients with polyarthritis, initially would start with simple analgesia while you're working them up. Try and avoid just beginning a patient on prednisone and not really having a working diagnosis, because what we often see is that this prednisone is just continued indefinitely, and patients are not timelessly referred for initiation of disease-modifying therapy. So really try with your clinical acumen to come to some sort of differential, and then that then guides how quickly you see the patient, as well as what investigations you're going to do to help to aid the diagnosis. So to touch on rheumatoid arthritis, and it's very important because most of the patients that are being referred to the rheumatology clinic are starting out in the primary healthcare setting. And these patients are often your female patients who are young, they're working patients, they're between the ages of 30 and 50. It's a prevalence of about 0.8% of the population. They present with symmetrical arthritis of the small joints of their hands, their feet. They have a significant early morning stiffness, as we mentioned, constitutional symptoms, and may have nodulosis or other organ involvement. The reason why we need to identify these patients is because 20 to 30% of them tend to be permanently work disabled within 3 years of diagnosis. So timeliest diagnosis of the disease process and early institution of therapy is key to help these patients from preventing significant morbidity in the future. So the 2010, also just to clinically quickly go through what you would see. So patients who present early on would just have acutely swollen, inflamed joints, particularly of their MCPs of their hands, their PIPs as well. As the disease progresses, they may have restriction in movement of their wrists. They can get an image, they can get Boutonniere's deformities, they can get swan neck deformities, they can get Z deformities of their thumb, and these are on radial deviation at the wrist, ulnar deviation of the fingers. And these are all typical changes that you would see in the more long-standing disease that would guide you to say this is rheumatoid arthritis. So the criteria for rheumatoid arthritis, and interestingly, this diagnostic criteria can actually be applied in the primary healthcare setting even prior to referral for patients. So you look at the number of joints that are involved, you look at the titer of the rheumatoid factor. If you're unless you have a really strong indication that this is rheumatoid arthritis, we don't recommend doing the ACCP in every patient unless you're really sure this patient meets the patient profile. It's a young female patient with early morning stiffness, then you can do an anti-CCP as well. Symptom duration, you want to have symptoms of more than 6 weeks, and looking at the acute inflammatory responses. So their CRP-ESR, if they score more than 6, then that's definitive rheumatoid arthritis, and that patient needs referral to a tertiary center to try and initiate therapy as soon as possible. And now we've divided rheumatoid arthritis into very early RA, which is presentation of joint pain and swelling under 3 months, early RA, which is presentation within under 12 months, and thereafter it's normal RA. So the reason for the distinction between the onset of RA is because what we found is that the earlier you institute therapy for rheumatoid arthritis, the better outcomes for patients. And that essentially lies in the screening and the diagnosis that gets done at the primary healthcare center. So as we mentioned, as your disease progresses, you go from swelling more to deformity. And very early on, when you have inflammation, that is essentially your window of opportunity to institute therapy to prevent the long-term deformity that patients can suffer. So just an important screening tool for when you're seeing a patient in primary health who has joint pain is if you press over the MCPs, we call it squeeze test, and there's tenderness, it's often a sign of inflammation of those MCPs. And again, over the feet, if you press over the MCPs, you do the squeeze test and there's pain, it's a sign of what we call metatarsalgia or inflammation of those MCPs. And that generally is associated with an inflammatory arthritis. So in general, for patients with arthritis, the UK early referral recommendations are if they have a positive squeeze test, if they have 3 or more swollen joints in early morning stiffness more than 30 minutes, then that patient needs to be referred for further investigation. So coming to the next form of polyarthritis that I'm going to be discussing is osteoarthritis. So osteoarthritis is also a very prevalent arthritis, and it's one of the arthritis which we can actually treat fairly competently in the primary healthcare setting. So it's the most common form of degenerative arthritis. It is due to destruction of cartilage, activation of an inflammatory response, and further destruction of cartilage as well as bone, and formation of new bone in the form of osteophytes. It leads to progressive joint damage and destruction, and eventually to disability. It's one of the leading causes of pain and disability worldwide, particularly in older patients. And as we mentioned, the structural alteration leads to pain and stiffness, as well as restriction of movement. And these osteophytes, which develop at the end, can also cause pain. They can cause tendon rupture and just general discomfort and bone swelling that's noted as well. The skeleton is important because it illustrates which joints tend to be involved. So typically osteoarthritis affects your weight-bearing joints, so the hips as well as the knees. You also have a predilection towards the first in TP. You get involvement of your axial skeleton as well, and that's your lumbar spine and your cervical spine. And you may also get a nodal form of osteoarthritis, where you get involvement of the proximal interphalangeal joints as well as the distal interphalangeal joints. And those patients may have nodes on the proximal interphalangeal joint, which we call Bouchard's nodes, and the distal interphalangeal, so your Hibben's nodes. So this type of patient is typically an elderly patient who comes in complaining of progressive pain in their hip. It's a non-inflammatory type of pain, so it gets worse at the end of the day, relieved by rest and relieved by analgesia in most cases. For patients with nodal OA, they may also have a degree of stiffness associated with it. However, it typically lasts for less than 30 minutes. And the presence of the node sometimes lead to disability, with them doing more fine motor activity in the home. Typically on examination, you may have a swollen joint, but they have what we call joint line tenderness. So for instance, if you're examining this at the knee, on flexion of the knee, if you're looking at the area in which your femur and your tip are meeting at the actual joint line, we have tenderness along this line. And the reason is because that is where you're getting your cartilage destruction occurring. So as we mentioned, you've got your Hibben's and your Bouchard nodes. On X-ray, you can see this osteophytosis, and you can also see the joint space narrowing. How we manage these patients. So generally it's analgesia in the form of paracetamol, non-steroidal if there's no contraindication. And importantly, there's no role for corticosteroid use in these patients. Often they get given prednisone for acute relief, and these tend to be continued, but the risk with use of corticosteroids is much worse than the benefit. In fact, there's actually no benefit in the disease process. What also should be encouraged is weight loss. A lot of the patients who suffer from osteoarthritis of the knee have very high BMIs, and that increases the pressure load on the knee. So even a minimal reduction in weight bodes to quite large reduction in the pressure upon the joints. They also, patients who are heading towards total knee replacements would require certain weight restrictions before they would even be candidates for surgery, so that becomes important. What can also be done is rehabilitation, and in the form of physiotherapy, so strengthening of the quadriceps can also sometimes try and help and alleviate the pressure on the joint. And if you find you've given your patient the maximum analgesia you have access to, they're still complaining of significant pain, you would x-ray them and refer them on for possible review by orthopedics to see if they would qualify for surgical intervention. So this essentially brings the end of the arthritis part of my talk. So it's a very broad topic, but in the primary healthcare center, as we said, your patient comes in with musculoskeletal pain. We need to try and determine, is the pain localized to the joints or is it articular? And if it is in the joint, is it an inflammatory process? Is it a non-inflammatory process? Is it one joint? So is it a monoarthritis, of what you consider particularly differentials, or is it multiple joints, polyarthritis? If it's a patient who you identify has gout or just has osteoarthritis, that's a patient you can probably adequately manage in the setting, primary healthcare setting. If it's a patient you're worried about a rheumatoid arthritis or any other form of polyarthritis that you're not comfortable managing, you need to refer that patient up as soon as possible for further investigations. Then to consider also other non-articular causes of pain. So as we said, areas around the joint, so rotator cuff injuries, or tendinitis, so epicondylitis, particularly the occupational risks, as well as bursitis. And patients with diffuse body pain may also be alluding to a connective tissue disease, fibromyalgia, patients with hypermobility, and also to rule out common endocrinopathies like hypothyroidism. So for this latter half of my talk, I'll be talking about connective tissue disease. It's an extremely broad topic, but just to highlight some flags for when you're seeing a patient with very non-specific complaints and what should flag in your mind that, okay, I think this patient may have a connective tissue disease and I need to investigate and also refer this patient timelessly. So connective tissue disease are systemic autoimmune disease in which tissue, cells, and matrix are disrupted. And this disruption occurs because of errors in your immune system or a dysfunction of your immune system and a loss of tolerance essentially to self-antigens. The different disease processes which we commonly see are systemic lupus, inflammatory myositis, or typically present with proximal weakness, dermatopolymyositis, systemic sclerosis, Sjogren's, mixed connective tissue, antiphospholipid, and systemic vasculitis. So what is important to remember about connective tissue is that they are multisystemic diseases. So patients may have complaints right from their joints to their skin, to their lungs, to their cardiac system, to their gut. So it often becomes a diagnostic conundrum, and often patients have very non-specific symptoms at the onset of the disease. As we mentioned, it's inflammatory immune mediated, and there's no single characteristic feature to say that this is definitely, or this patient is definitely going to go on to develop an autoimmune disease. And the diagnosis often is guided by your clinical findings. So in terms of the prevalence, and these are quite rare diseases. Rheumatoid arthritis, as we said, 0.8%, lupus 0.04 to 0.1, scleroderma and poly and dermatomyositis even rarer. But you don't want to miss that one individual because these diseases are extremely debilitating. With respect to age and gender distribution, so your lupus patients are typically your female patients of childbearing age with a female prediction of 1:9:1. So when you see a young female patient who has non-specific complaints, weight loss, joint pain, rashes, they may have cardiac complaints or palpitations, they may have shortness of breath, they may have puffiness, and you need to consider, could this be an autoimmune process? Scleroderma, again, occurs more in female patients, so slightly lower predilection of 4:1. It occurs typically in the ages of 30 to 50 years old, and your inflammatory myositis, particularly dermatomyositis, there's a bimodal predilection, so 10 to 15-year-olds, and again in older patients. So how do we make a diagnosis of a connective tissue disease? So you have your ancillary things. So you have your criteria, which is often drawn up when research is being done, and it's lots and lots of studies and evidence. You have your laboratory investigations, which point towards certain disease processes and are markers of what's happening on the level of your immune system. And you have your special investigations. But all of these things center around recognizing the clinical features through a detailed history and examination. So what are the clues? So clinically, as we said, so we touched on some of them. So it's constitutional symptoms, fever, fatigue, weight loss. You do your standard, you do a RBD test, and the patient's HIV negative. And now you have to think, what else could be causing my young patient to be losing weight, having this non-specific fatigue? Rashes often tend to be the earliest feature. Arthritis, Raynaud's phenomenon, so that's a reactive vasospasm where they tend to get color change in the fingertips, and that happens more in colder weather. And they typically have the color change from a white to a blue to a red appearance. Zika symptoms, dryness of the eyes and mouth is associated with connective tissue disease. They may have weakness, or particularly we see proximal weakness. They may have unexplained thrombotic events or major organ involvement, as we mentioned. The laboratory investigations to do when you're concerned about a connective tissue is initially to keep it quite simple. So you would do a full blood count with a differential. You want to check that there's no cytopenia, so particularly anemia contributing to their fatigue. In patients with connective tissue disease, because you get immune inactivation, they get lymphopenia because their lymphocytes often get drawn to other sites in their body and they get a circulating lymphopenia. So that's one of the clues. They may get thrombocytopenia. They, as a whole, they can have a leukopenia, and they may not have an anemia, be it from hemolysis or anemia of chronic disease. They have raised acute phase reactants. You would do an ANA, so anti-nuclear antibody test. And if you're concerned about possibility of renal involvement, you'll check for urine sediment or urine MCNS, as well as urine protein level. So the classification of lupus has actually changed over the years, and the last classification criteria we have is from 2019. So we're not going to go into detail with this, but what's important to know is that the entry criteria now for lupus is a positive ANA. However, that is generally only done in the setting of a high clinical index of suspicion. So you don't want to just be doing ANA on any patient who has fatigue. You really need to have some form of clinical suspicion that this patient could have a connective tissue disease before you do an ANA. Once you have a positive ANA, then you apply your diagnostic criteria for lupus. And it's now a weighted criteria with inclusion of multiple systems together with immunological result. So some typical rashes of lupus is photosensitive erythematous rash. So patients report when they go in the sun, the skin becomes very red. They may also report pruritus, fine vesicular rash. Patients report alopecia. So they may either have quite marked areas of hair loss. But what we often see is more just thinning out of the hair, so very sparse, brittle hair. And patients often note this change in their hair quality with the onset of the disease. The discoid rash of lupus is something that you would, once you're familiar with it, you shouldn't really be missing if it's this extensive. It's typically these large plaques which have hyperpigmented areas on the periphery and central hypopigmentation. When it starts, it can be quite erythematous as well. So sometimes it's a bit difficult to differentiate from the malar rash of lupus, except remember that your malar rash of lupus is a butterfly erythematous rash over the cheeks, and you get nasolabial sparing. Whereas with your other rashes of lupus, that are discoid or subacute, you can get involvement of the nasolabial fold. The malar rash, or the typical butterfly rash of lupus, also heals without scarring, whereas your discoid heals with scarring. And often it tends to heal with this hyperpigmented periphery and this hyperpigmented center. If it occurs on the scalp, they then have scarring alopecia as a result. So patients can also present with oral and nasal ulcers. These are painless ulcers. They may have a history of mucositis, so just erythema or pain on the lips, and that can heal with depigmentation. And they may report Zika symptoms, so kind of redness of the eye. They typically on history will say they have grittiness or stand in their eye, and they have very dry mucous membranes, so xerostomia, and that can lead to poor dentition. So, and as we discussed before, they can present with arthritis, it's polyarthritis, or even oligoarthritis, And they have a lupus, what we call Charcot's arthropathy. So this is a non-erosive arthritis. So if you x-ray the patient, you don't see these stark erosions, and a lot of these deformities are actually reducible. So although it looks quite severe, if you actually pull in these fingers, you'll see you'll be able to straighten it, and that's what we call a reducible deformity, because the changes are not because of destruction at the level of the bone, it's more because of inflammation from ligaments. So that is, or those are the key features that you're going to, or that will increase your index of suspicion for a patient having lupus. So moving on to your inflammatory myositis, so dermato and polymyositis, we have your Peter and Bowen classification criteria of 1976. And essentially your classic dermato and polymyositis presentation is that of a patient who comes in saying that they're getting progressively weak. A lot of our patients, it will be affecting their ability to function at work. It typically affects the proximal muscles more. And generally it happens in both upper limbs and lower limbs, although you do get the cases where it's lower limb or upper limb predominant. They may or may not have associated rashes, and the presence of rashes would point more towards dermatomyositis. The rashes that you would look out for are the heliotropic rash, or this erythematous lace-like rash around the eye, the V sign, which would be on the anterior neck, the shawl sign over their back, as well as what we call Gottron's papule. So these raised erythematous plaques, which are actually markers of vasculitic processes over their PIPs, their MCPs, and ragged cuticles. These are your signs that will, together with the presence of muscle weakness, that should make you think, could this be a dermato or polymyositis? So moving on to systemic sclerosis. Systemic sclerosis is marked by skin thickening together with systemic involvement. So typically they have a vasculopathy, so they commonly present with Raynaud's phenomenon. So patients would have this color change. You can see there's a marked change in their finger. It can be one finger, but typically it, when it's a secondary or pathological cause of Raynaud's, it tends to be all of the fingers, including the thumb. And you need to worry if Raynaud's occurs in an older patient, it's asymmetrical, the patient has a positive ANA, we start developing complications, so the presence of these digital ulcers. And if you can put some KY on the tip of their nail and look with an ophthalmoscope, and you'll see these abnormal capillaries at the nail bed. And this just points to a patient who has Raynaud's, and this is as a result of a pathological cause. Because remember, you can, particularly in young female patients in the winter months, Raynaud's can be a benign condition. It's primary Raynaud's. And patients just during the winter months, young females get these vasospasm events and they get typical Raynaud's. But once it becomes complicated and there's abnormalities of the capillaries, there's digital ulcers or pits, then you know there's a pathological process behind it and you need to look for it. So with systemic sclerosis specifically, they tend to get thickening of their skin that's proximal to the MCPs. So initially they'll have puffiness of the fingers, which we call sclerodactyly. They can develop ulceration because of the tightening of the skin, and that skin thickening tends to extend beyond the MCPs. Because of the skin thickening, they aren't able to oppose their fingers, so they will have a positive Crayer sign on examination, and they may have flexion contractures. They also develop telangiectasia, which is often quite difficult to see in our Black population, but if you look very carefully, they can have telangiectasia on the skin, and sometimes you can also see telangiectasia in the buccal mucosa. Then they also have calcinosis, together with a history of significant reflux. These signs should increase your suspicion for a patient with systemic sclerosis. And apart from doing your ANA, this patient needs to be referred out for further investigation. Livedo reticularis is one of the rashes we see in our vascularity or vasculopathy of antiphospholipid syndrome. So a patient who has a history of clotting, a history of miscarriage with libido, you need to be concerned about antiphospholipid syndrome. Vasculitis also is one of our rarer immune-mediated conditions, and patients present with either palpable purpura, these tender fingertip lesions, or gangrene of their fingertips. And again, these patients need investigation. As we said, with the arthritis, as well as with your connective tissue, patients can have non-specific complaints. They can have multisystemic complaints. They can have pleural effusions, interstitial lung disease. They may have respiratory complaints when you see them. They may have cardiac or even GIT complaints. So important points when you're checking for an ANA, you only do an ANA or request an ANA in a patient where you have a high index of suspicion for connective tissue disease. So the patient is in the right the right age category. There's something clinically that's making you suspect this is a connective tissue disease, and then you request an ANA. And the reason is because, as you can see on the right, you've got your autoimmune disease, where in patients with lupus, more than 95% will be ANA positive. But then on the other side, you have your non-rheumatic causes of a raised ANA. And importantly, at the bottom, 15% of healthy adults can have a positive ANA. Yes, the dilution, as you dilute it, the percentage of patients become, or people, normal individuals become less, but we don't want to, at the same time, over-investigate patients. So not every patient with fatigue needs an ANA. You interpret their history together with clinical signs and then request your investigations. The ANA, an abnormal titer, we consider a higher titer of more than 1:160. However, the most recent EULAR criteria for diagnosis starts the entry criteria of 1:80. So if it's below that, it's actually not significant. There's no role for repeating ANA. So if you've got an active ANA, you wouldn't really need to repeat it on multiple visits. And ordering tests beyond that should only really be directed according to what diagnosis you're actually suspecting. And that would be more at tertiary level. So as we mentioned, the basic investigations you could do is your renal function, your FBC with differential, acute phase reactants, rheumatoid factor ANA, checking urine, as well as x-rays of the chest, hands, and feet. So management principles I'm just going to touch on, because often the management is then done in the tertiary centers. Is number one is obviously education, multidisciplinary care, making sure your patient understands the disease process. We aim therapy depending on which organ is involved, and that therapy is individualized for the individual, for the disease, as well as for the organ manifestation. We giving patients very high dose immunosuppressive therapy, and with that comes its own host of side effects and complications, which we need to be aware of. And generally, we use corticosteroids in acute phases of disease. And I think this is an important message to understand, is that corticosteroids have a lot of side effects. So no patient, be it in primary, secondary, tertiary care, should be on long-term corticosteroids with no plan to actually stop these, unless, very few cases where we would do that. So whenever writing up a corticosteroid for a patient, prednisone, for whatever reason, you need to have an end game in mind. So what is my goal? Am I putting them on a short course of prednisone because I can't use an NSAID, I can't use simple analgesia, but I think this is a rheumatoid, so I'm going to refer this patient immediately? Or am I just doing it because I actually don't know what's going on? And I think in that situation, you avoid your corticosteroid, because your long-term risk to that patient of developing complications, right, from hypertension, diabetes, osteoporosis, avascular necrosis, it's much greater risk to the patient. And then with all our disease processes, we address the comorbidities, so informed infection, osteoporosis, and cardiovascular. So the take-home messages of today's talk is rheumatological conditions can manifest in multiple ways. You have your patients with arthritis as their predominant signs and symptoms, of which I think we should all be comfortable in diagnosing or recognizing gout, treating gout with a treat-to-target approach, which is very important, because control of the disease has huge implications for that individual patient and their functionality. Recognizing osteoarthritis and doing whatever we can in terms of supportive therapy to aid that patient's pain and functionality, as well as recognizing when we need to refer patients on for further assessment, particularly in younger patients, or patients with concern of rheumatoid arthritis, patients who need institution of disease-modifying therapy as early as possible. And then your patients with connective tissue disease who present with a whole host of signs and symptoms. I think it's just being comfortable with recognizing in which categories it can fall. Is it a rash? Is it arthritis? Is it a patient who's progressively becoming swollen with proteinuria? And recognizing that not only, but also referring them out for investigation. And this timeous referral would be, early referral, it's a timeous diagnosis. And that allows for initiation of therapy and ultimately better patient outcomes. Thank you.
Thank you very much. Yes, there's some questions you can have a look at.
Sure. So there's a question by Nompumelelo Tekwane, and the question is, what level is rheumatoid factor regarded as a high positive? So with rheumatoid factor, you have a low positive and you have a high. You have a low positive and you have high positivity. So we typically look at a rheumatoid. So if you look at the lab parameters, they'll give you a rheumatoid factor of less than 10 as being negative, and if it's more than 10, it's positive. And what the ACR criteria look at is a level that's more than 3 times the upper limit of that. So typically a level of more than 30 is a higher positive. And when it's between 10 and 30, it tends to be a lower positive value. And you would get different scores when you're applying your ACR criteria to the patient. So that's Nompumelelo Sekwane. And then
if I can just quickly, Nirvan, before we go to the next question, ask people to fill this in, just so that we get a sense of who's in the room. Fill in the poll and just give us a sense of who's around. Carry on, Nirvan.
Sure. And the second question is, how does one diagnose psoriatic arthritis? Are there specific lab investigations, or is it more of a clinical diagnosis? So this is a very good question. So psoriatic arthritis falls under the category of a seronegative spondyloarthritis. So what this means is, often their serological tests are negative. So they will have a negative rheumatoid factor, a negative ANA, a negative ACCP. So very little in the way of laboratory investigations to prove it. They also are considered in the category of spondyloarthritis. So their presentation can involve both the axial skeleton as well as the peripheral skeleton. So how we diagnose psoriatic arthritis is a combination of clinical as well as X-ray features. So typically patients may have psoriasis, so they have the skin rash. They could also have a family history of psoriasis.
Sorry, I'm just sharing
changes, so they get these onycholisis. So, they have involvement of the DIPs, which is not typical of patients with rheumatoid arthritis. So when you see inflammation of your DIP joint, you need to flag in your head, could this be psoriatic arthritis? They also have involvement of your PIP joints. And on X-ray, as opposed to patients with rheumatoid arthritis who have erosive disease, in psoriatic arthritis, they have new bone formation or bone hyperostosis. And that helps you differentiate. And this is called the Casper criteria. And it's essentially criteria that you can apply at the bedside to try and establish whether this patient has psoriatic arthritis. The other thing is that with your seronegative spondyloarthritis, they tend to present with other clinical features. And that is dactylitis, so swelling extending beyond the joint. So they get these sausage-shaped digits. They can have enthesitis, so Achilles tendonitis, and tendon insertion points. They can be tender. They may have inflammatory lower back pain. As we said, they can have DIP involvement, and sometimes they can have association of rashes, so psoriatic rashes, but they can also have GIT complaints. So these type of things actually help us differentiate more based on clinical findings and history, or to identify psoriatic arthritis.
Thank you very much. I think those are the questions. Just a last question from me. Do you think that DMARDs have any role that can be used in primary care? I mean, are there certain conditions that you can use certain DMARDs that would be possible in primary care? Probably more capacitated or resourced primary care settings, like a general practice.
Oh, sure. So it's difficult. I think it comes with the with having good knowledge of the DMARD that you're instituting to be able to adequately monitor the side effects of that therapy. So in a patient who has simple rheumatoid arthritis with no other extra-articular manifestations, you could possibly institute a methotrexate at a primary care level. However, again, that comes with monitoring their blood counts, ensuring that they don't develop cytopenias, knowing in which patients you need to dose adjust, knowing how to up-titrate therapy. And I think in that setting, with that knowledge background, you could easily institute DMARDs for, I think, more so rheumatoid arthritis than any of your other connective tissues in a disease. Yeah.
No, thank you. I really loved the pictures, and I think that was really neat. And I think you really took it very well as a, for the primary care focus, looking at what's common. So really appreciate your presentation. I think we're almost up for the hour. I don't see any more questions. I think Dr. Kabir just added the comment about methotrexate as DMARD to use, but I think that's fine. So thank you, Nirvana. Really appreciate your time. And as you can see, it's far beyond Joburg. It actually has people from all over the show. And next year, we hope you'll do some more with us. And we want it to be, across Africa with many more people, including those in Johannesburg. So anyway, take care, everyone. Go well, enjoy your festive season, and be safe. Thanks, Dr. Bertram. Bye-bye.
Thank you. Bye.